Hello, everybody, and welcome to tonight's Frankly Speaking About Cancer. Tonight, we're talking about making treatment decisions, and here to present with us is a great friend of Gilda's Club, Dr. Julianne Childs. She is the medical director of the Hope Community Cancer Center in Memora and Cape May Courthouse. She is also the medical director of the Shore Cancer Center. And Dr. Childs has been a long time...
Formally. Yeah.
So Dr. Childs has been a longtime supporter of Gilda's Club South Jersey. We even operate a site in the non-COVID times in her center in Cape May Courthouse. And she's also been a longtime member of our professional advisory board. So for those of you who are joining us tonight on Facebook, you can enter your questions in the comments and I will read them to Dr. Childs when we get there. And thank you so much, Dr. Childs, for joining us, and the floor is yours.
All right. Well, thank you, everyone. And those of you who were on time, I'm sure you enjoyed our little pre-talk, getting the computer ready. It's always interesting for me to do 3 things at once on my computer. Anyway, this is a slideshow that's been prepared to kind of help people know maybe how to speak to their physician, ask questions, make decisions about their treatment plan when they are faced with a diagnosis of cancer. So we'll start from here. I think we can skip this slide. So this was developed by a cancer support community, and they developed it independently, getting medical and psychosocial experts to review it. And my husband's coming up with the dog. And it was sponsored by Pfizer, who also, as you may have heard, have come up with one of the vaccines on the horizon for COVID, and Gilda's Club. And I'm not being paid by Pfizer, unfortunately. So basically what we're going to do is try to learn how to recognize treatment needs and how to respond to those, try to be knowledgeable about our diagnoses and treatment options, learn how to build a support system, ask questions and advocate for what you need, and information for caregivers, and also for them to help with treatment decisions, helping their loved one make those decisions. And the bottom line is doing what's best for yourself. So you or your loved one may have been diagnosed with a cancer, but that doesn't mean the cancer defines you. One of the things I try to teach students and residents is don't look at a patient as a diagnosis, because that's not what they are. One of my favorite things to do is to ask them something personal about themselves so you know them as a human being, not just a diagnosis. But the patient themselves doesn't want to feel that way either. They need to educate themselves, get support, and have hope and courage. So some of the things that you want to talk to your medical team about would be your age. What point in life are you in? Including family life and work. What's your overall health like? What are your expectations for treatment? And getting available resources and support system together, and letting your physician and the medical team know. And then there are logistics, including transportation needs that you might need. Costs, that's a question that you can ask. And then anything else that's on your mind, you should be able to bring up to your team. You want to be empowered. You want to set your own goals, plan a strategy for each goal, find resources, and ask for help. Don't do it by yourself. Take action. You know, you're in charge. You may not be able to control the diagnosis, but you can control the other things around you. Treatment decision-making is a shared decision between you, your family, and your physician and the team. I should say physicians. Shared decision-making is relationship-based, and it's you and your healthcare team that We'll be discussing the treatments that align with your values, your goals, and your current living situation. So, when you're talking about your physical, emotional, sexual health, and well-being, the things to think about would be what are most important to you to be able to do. When it comes to your family and social relationships, what's going on in the lives of others that's important to you. And then there's work for people, school, home. Do you want or do you need to continue working? Can you adjust your schedule, your responsibilities, your career goals so that you can do a little bit of everything so that you're not totally giving up what you love to do? And are you getting help to do, tasks at home like cooking or cleaning? I'm sorry for the background noise, but there is a puppy over there. And she's not a happy puppy apparently, but she'll live. So then there's community involvement. Are you getting support you need from your community? Are you able to stay active and involved in your community? Are you taking care of your own personal and spiritual growth? And what other things are important to you? I'm having a little computer issue. Here we go. That's good. Samantha, I don't know if you're able to advance slides as well. Let's see if this works now. Huh. Oh, Lordy. Thanks. It's important that you think of your values and what matters to you. For instance, being active with your family, being healthy enough to attend an affair. So there are many times that we'll plan someone's chemotherapy treatments around, say, someone's wedding, pre-COVID, of course, or some other important, the birth of a child, a grandchild, or anything like that. We try to plan it so that you'll have as few side effects for those things as possible. And we want to weigh what's the best treatment available no matter what. And you can choose that option of what is the best treatment for you by looking at the side effects of the treatment as well. And also, like, how important would it be for you to be in a clinical trial? Some people are very gung-ho to participate in trials because they like the altruistic nature of it. They're advancing science. Some people don't really want to. And part of that is has to do with maybe travel. If you're offered a trial and the facility's 2 hours away, that might be too difficult. And I'm still not able to advance the slides anymore, and I don't know why. Thank you. So there are some helpful tips. Cancer journey has many decision points along the way. So some of the tips would be try to do things in small bites, one step at a time. Don't try to manage everything all at once. You set short-term goals. Okay, tomorrow I have to get my CAT scans done. And then stop at that point, like say, okay, I'm going to get that done first, and then I'll think about what's next. And when you're with your physician, you can ask, can I have a written treatment plan? For instance, how many cycles of treatment do I need? How many days in between each cycle is there? Can you make me a calendar, or can one of the oncology nurses make me a calendar so I know what's coming up and I can plan? It's working now. You can ask your doctor exactly, well, you should ask your doctor exactly what kind of cancer you have, we're happy to write down anything you need and to provide teaching information for you. And if you don't understand, just remember it took us years to understand this stuff. It's probably impossible to understand everything that you're being told in one sitting. So we purposely repeat things over and over so you can kind of get it. You can have copies of your lab reports, copies of your dictations from that day. Most offices and facilities have a way that you can go on the web and you can pull up your own results. You can ask your doctor what they base their treatment recommendations on. And you can also talk with the nurses about that. Typically, physicians are going to be purposefully choosing the standard of care, utilizing either ASCO, which is American Society of Clinical Oncology guidelines, or the National Comprehensive Cancer Network guidelines. And these are guidelines that are put together by teams of physicians who are specialists in your particular type of cancer. And they go through all of the literature and all of the studies that have been performed, and they come up with what's the best treatment available for what you have. And then another way to help understand what's going on is you can talk to other people who have cancer. And of course, Gilda's Club provides you with other people who are going through similar things. One thing I tell people to try not to put all of your questions and understanding into like chat lines on the computer. Certainly there are some that are very good, but sometimes there's a lot of misinformation. I've gone into them and just kind of watched as an innocent bystander, and you just have to be a little bit careful. If you hear something on the internet that concerns you, or you wonder if it really is true, just ask. So, what kind of cancer do I have? You ask that question, and then what is the stage of my cancer and what does that mean? So for instance, if I told a patient they had stage 4 low-grade lymphoma as opposed to a stage 4 lung cancer, they actually have very different meanings in terms of what prognosis is, what treatment would be. So it's more than just hearing that number 1, 2, 3, or 4. What kind of symptoms from the cancer might I experience is a good question, and what kind of test do I need to best evaluate me now in the very beginning before I start any treatment, and then afterwards, after I've had some of the treatment, to see, how long do I wait till I can see if there's been a response, or how do I know when I'm done, that kind of thing. And then I always, I try to ask patients if they want to get a second opinion, if I feel that they are, they want to get affirmation that what they've heard the first time is correct. And sometimes I tell the patient myself that they need a second opinion at maybe an academic center. For instance, for someone with multiple myeloma, part of their treatment is a stem cell transplant, and that's standard of care. But we don't do those in community hospitals. We have to rely on the academic centers that specialize in that very, very detailed and, specialized care. So second opinions can go both ways. We can recommend them and you can ask for them. Your choice of a doctor and choice of a cancer center depends on the type of cancer you have and the stage. Whatever your preference is, you should choose where you feel most comfortable. It's your choice. I should say, except for insurances, sometimes they won't let you do exactly what you want to do, but usually everything works out. Some patients might not be able to go to Philly for a second opinion. They might have to stay on the Jersey side, but there are excellent academic facilities in Jersey just as well as Philly. maybe just a little bit more traffic or something. And then logistics such as the transportation, the cost of traveling back and forth, how far do you have to go, can you get a ride, those kind of things. And usually there is a way for the physician's team at their cancer center to kind of guide you into where you can get extra help for things like that. So the members of your team could include a medical oncologist, that's the person who recommends chemotherapy type of treatments, nurses that are oncology certified, there could be surgeons, surgical oncologists or specialized, pathologists, you'll never see them, but they're extremely important in your care. Radiologists, once again, you probably won't see them. Occasionally you will, but they're also very important. Then there are radiation oncologists, which that's kind of intuitive. They're in charge of developing radiation treatments for patients. The dosimetrist is someone who works with the radiation oncologist to decide what are safe doses to administer. And then there's the therapist in the radiation department that actually will help you through your treatment. The physicist is, I always find this fascinating. There's actually someone who is a physicist who is in charge of making sure that everything with the radiation therapy from a standpoint of the machines working and being able to deliver the proper dose is on board. So it's a lot goes into that. Your family doctor has to be around too. A lot of people don't want to keep going back and forth between all these doctors, but typically the general practitioner is going to be in charge of things like your blood sugar and your cholesterol and your blood pressure. All of these things are really important. We have to work together as a team. And then social worker that or someone who fills that spot that can tell you, okay, you know, if you need some extra money because work's been difficult to get to, there are different funds you can obtain, you know, without having to pay them back even to help you through tight spots. Other members of the team would be a pharmacist because they may be involved in either helping to mix the chemotherapy or help you in your local pharmacist get the medications you need. A psychiatrist or psychologist might be helpful for all of us, I guess, you know, to get that part of our whole body taken care of. You can't separate the mind from your body. It's all one. Registered dietitians can be extremely helpful. Plastic surgeons, if you need some kind of reconstruction or maybe revamping of a scar to make you feel better emotionally and physically. Rehab specialists can be important. Home health aides, when you are, say you're discharged from the hospital and you need help at home or you just need some help, that can be very useful. Hospice care is extremely important when it's determined that to give a patient more chemotherapy is going to hurt them more than the cancer is. Well, then it's time to stop that therapy. And then what we do is concentrate on treating the symptoms of the disease, not just try to keep pummeling the disease itself. And so hospice can be important. They can provide supplies, hospital bed, wheelchair, oxygen, any kind of medications that you're on will be delivered to the house. They also will provide home health aides, and they can access clergy and social workers and physical therapy and all of those things as well. And then clergy stands alone as a group of members of your healthcare team that can help. So when you go to your doctor visit, it is helpful to write down questions because I know even for me, if I'm a patient, you forget what you wanted to ask. And by the time you're done with the visit, the doctor's, you know, out the room and you miss the opportunity. So it's good if you can remember. And having a little booklet to keep a record. I felt this on this day after my treatment. It might give the doctor a clue as to what would be the best way to handle that. And like I said, having the questions written down really helps. And if you can bring a family member, and in this time of the pandemic, it's a little tougher because we try to keep the people coming into our offices down to the bare minimum. So we try to do things by FaceTime with a loved one while you're in the room and we're all talking together. They're just not physically there, but they could take notes for you. And it's important to keep a list of your medicines that's accurate. So when you come to the doctor, if you have that accurate list, we can make sure we know what you're taking and make sure that everybody's on the same page. Trying to stay focused on what's happening right now rather than trying to make decisions about everything all at once. I think that's just good advice for life. It can be pretty overwhelming trying to decide everything. So small tasks to start with, and then you feel accomplished and you can move forward. But if you're having stress over issues of finance or insurance counseling, you can always ask and we can find someone to help answer the questions better than maybe the doctor wouldn't be the person to ask about that kind of stuff, but I'll find the person who knows. And then it's good to know how you're feeling about things that have been discussed. And do you feel like you've got an understanding of what's happening? Some people, they want to know every detail, and that's a good thing. That way, if you need to explain it to another physician who you're just now seeing, or if you have to go to the ER for something, then you can say, hey, look, this is what my story is. I have this, I'm getting this treatment. I had it the last time about a week ago. It helps everybody take better care of you. And here's where I was talking about before, taking advantage of available resources like the South Jersey Cancer Fund or Leukemia Lymphoma Fund, American Cancer Society. There are many, many, many places that you can try to get some help. And then, of course, talking about treatment options is a big deal. You can choose treatment options that are equivalent in terms of how well they work, but you can, as a physician, I can choose, okay, based on the side effects that treatment would cause. So if I have someone who's a concert violinist and I have drugs that are going to cause numbness and tingling of the fingers, maybe if there's another treatment that's just as good, I would pick the other one so I wouldn't risk causing the numbness or neuropathy in that person whose whole life is about their violin. And the same thing goes for if I have someone who's working in any kind of a store. Let's make it a pet store. And if the drugs are going to cause diarrhea and they have to keep getting up and leaving the cash register or leaving the animals or what have you, because they're getting diarrhea all the time, well, that's not particularly helpful. So maybe I would pick the opposite treatment. But there are a lot of ways that we would choose. And you want to know what the goal of the treatment is. Is it for cure? Are we intending on giving you chemotherapy to make the cancer go away completely for good? Or are we treating cancer that we can palliate? In other words, try to keep in check so that you have good quality of life for as long as humanly possible. What are the benefits of the treatment? And what are the side effects? And what are the reasons to choose what we choose? And then, they're bringing up costs here. Typically, insurances are going to cover whatever the doctor is recommending, unless it's something totally off the wall and it's never been done before. You're safe that way. They won't let us do things that are completely experimental or crazy. But usually if I say that a patient needs this drug because it's safer for their lungs because they've been a smoker and I don't want to give them this particular medicine, I need the other one. Typically, if I justify it well enough in my note on you, my medical records, they're going to say, oh yeah, good idea. Let's be safe for the patient. Focusing on evidence-based standard of care medicine, and I talked about that a little bit before, the NCCN and the ASCO guidelines, they tell everybody from Philadelphia to Arizona, what are the best treatment options available for patients? What is, they'll even put in there, what is the first choice treatment? What should you start with? And then we discuss that, and if there's something about that treatment choice that's not going to be good for the patient, then we talk about what would be next best, and we make a decision together. The two basic approaches to developing these standards are called guidelines and pathways. And guidelines tell us they're based on a specific subtype or a genomic profile or a stage of the cancer. So genomics is a really big deal these days. It used to be that the only treatment we had available for patients was geared towards just killing cancer cells with toxic substances and suffering the consequences of the normal healthy cells that might be also affected by that type of treatment. I'm not saying that we don't use that type of treatment. We still do because it still works. But moving ahead, the way that we're treating many cancers is by first taking a piece of the cancer, sending it for special studies called genomic profiling, and what's actually being done is the cells are being examined for mutations. If they find a specific mutation that has a drug that's geared specifically towards treating cells with that mutation, then you have a treatment that is specific to the mutation itself and perhaps would cause less side effects, but may be more effective than chemotherapy. So, for instance, in all lung cancers, for the last several years, we've been doing genomic profiling. If someone had, for instance, something called an EGFR mutation, there are drugs that can be utilized specifically for that. Chronic myelogenous leukemia is the best example because it's the first example where there are drugs that specifically hit the mutation that causes that disease. And those treatments are so specific and so good that some people, after a couple of years, can come off the drug and stay in remission, which is something we never could do before for that particular disease. So the guidelines tell us, okay, when we're supposed to do genomic profiling, when are we supposed to use standard of care therapy, what is the very best treatment, and actually in the NCCN guidelines, they do look at cost effectiveness of the medicines, but as I said before, all of the physicians are looking at what's best for the patient, not what the cost is. We just want what's going to work. Pathways have been shown to improve the quality of care by ensuring that patients receive proven therapies rather than unproven or too expensive of choices that aren't any better in terms of benefit. And they also can include preferred drug choices, as I said. And I don't get any financial incentive for adhering to these pathways. I guess Medicare likes it when doctors can show that they're cost effective, and that also in that cost effectiveness, we're increasing survivals of patients and things like that. So in that way, if you can prove you're cost effective and providing excellent care for your patient, that's what they're interested in. That when they say financial incentive, it means they'll actually pay us for our work. Not a bonus, not a bonus. Questions to ask about your treatment options. Once again, what's the goal of the treatment? Why am I recommending the therapy? What are the benefits and the risks of each treatment? And how can we prepare for and manage potential side effects? So the goals could be either curative or palliative, depending on if there's a reasonable expectation of cure or not. Why are we recommending this treatment? So if I have someone who has very extensive lymphoma that is considered to be a more intermediate grade or high grade lymphoma, my treatment may be extremely aggressive, but the trade-off for being so aggressive, which means maybe more toxicity, is that it's got a better chance of curing the patient. So my goal for curing someone might take into account that if you're okay with this concept, you may get more side effects, but we'll get you through it. If I'm trying to treat someone who I know I can't cure, but I can make them at least maybe feel better, shrink the cancer, decrease pain, things like that, then I'm not going to pick a treatment that's going to make them sicker than the disease. I'm going to pick a treatment that works but is tolerable. So there's different ways to choose. And then what are the benefits and risks of each treatment? You'd want to know that. And how do you prepare for the side effects? And that's important too. Usually I tell patients the first treatment of anything is going to be the hardest one because you have no idea how it's going to affect you. You're not going to get every side effect on the page that, all of the things that they list that could go wrong. You're going to get one or two of them. And I can't predict looking at you which ones those are going to be. So you get the first treatment, you know what generally to expect, what are the most common side effects. And then after that first treatment, if you say, I got really constipated with that treatment, what do I do? Well, we tell you to go on a bowel regimen, maybe starting the day before you're going to get your treatment so that that doesn't happen again. But if we gave you the bowel treatment beforehand, you might get too much diarrhea, and then we'd be, you wouldn't be happy either. So sometimes it's just an individualized thing. Once again, we want to explain to our patients, how often is the treatment given? Where will it be given? How long is the infusion going to take? Is it IV? Is it a pill? How long, like I said, how long are the treatments? How many days do I have to take the pills? If it's pills, I get to take it home. And does the facility where I'm treated also give resources for emotional support? And that's where Gilda's comes in. So as you may have ascertained when I was talking about the different type of doctors involved in your care, treatment options include chemotherapy, radiation therapy, surgery, targeted therapy, which goes back to if I know there's the genomic profile shows a specific mutation, I'm going to pick the drug that's targeted towards that mutation and maybe not need chemotherapy. Use those things first. And immunotherapy, which is also another very huge discovery in the last several years. And whereas initially we used immunotherapy only for perhaps melanoma and renal cell cancers, any cancer that has certain genomic markers might be a candidate for immunotherapy. It doesn't matter what kind of cancer it is, if it has the right profile. And it's standard of care for many, many, many cancers now. And it's different because it doesn't cause side effects that standard chemotherapy has side effects that we could predict in, so, you know, I can tell a patient that 10 to 14 days after your chemotherapy, your white count's going to be at its lowest point. The white blood cells will be, and that will be a time where you're at risk for infection. With immunotherapy, you could get no side effect. You could get something as mild as a rash, or you could get some autoimmune effect from your immune system being too hyper, something as rare as pulmonary complications because your immune system decides it doesn't like your lung cells. But there are many, many different things that go into immunotherapy that are unique to it. But by a long stretch, most people tolerate it very well. So this is kind of reiterating what I've said before, that chemo is kind of, we used to use the term slash and burn because it would kill the cancer cells, but also hit many of the normal cells as well. Chemotherapy can be IV, pills, it can be applied directly to the tumor, for instance, in liver-directed therapy, where they actually will shoot the therapy right into the arteries that feed a particular part of for instance, the liver. Chemotherapy is called systemic therapy. That means we're trying to keep cancer cells from going anywhere else in the body, systemically. Radiation therapy can be external, where they're shooting the beams from the outside, and it can be internal. It can be put in seeds that are implanted in a specific place, or for breast radiation therapy, sometimes they'll do a procedure where they're actually putting the radiation pellets or use a certain technique to allow for radiation just in the area where the cancer was. And it may take only a couple days to perform that, or maybe only one therapy for that, 2 sessions in one day. Internal radiation could mean intravaginally if someone's had a cervical or uterine cancer. And they also use radiation delivered through the arteries into the liver, believe it or not, which can be extremely effective. And usually the physician's going to use as many of these therapies as they can to keep your disease controlled or to cure it, or for whatever reason. You know, the most common form of treatment of cancer is surgery, and it can be used alone or it can be used in combination with other therapies. For instance, a breast cancer, we talk about local control of the disease and systemic control. So the local control is the part where we're trying to keep the cancer from recurring to where it started, in the breast. So the surgeon could do a lumpectomy, and then the radiation oncologist could prescribe a course of radiation therapy. And then after that, you go see the medical oncologist, and they tell you what would be the best treatment to prevent the disease from going anywhere systemically. And surgery is used not only for treatment, but also for the diagnosis. It tells you, you know, it's crucial to know what kind of cancer you have. So a tissue biopsy is very important. Surgery can also allow for staging, which then allows for the treatment. So in colon cancer, the surgeon goes in and takes out part of the colon, and surrounding part of the colon are going to be little lymph nodes. And the pathologist comes in and counts how many lymph nodes have disease in them. And in colon cancer, if there's involvement of lymph nodes, it means that chemotherapy would be of great benefit to decrease the likelihood of recurrence. So the surgeon is necessary for helping us know that. Surgeons can also debulk the tumor, meaning make it smaller. So, and a good example of that would be ovarian cancer. They go in and they do a surgery and they try to remove every last bit that they can. And they may know that they've left a little bit behind, but they call it optimal debulking, trying to remove as much of that disease as you can, and then the medical oncologist gets to give some systemic therapy to try to keep those cells beaten down so that they can not recur for a long, long time. And then there are surgeons who perform reconstruction. So in breast cancer in particular, that's very important. And some of the reconstructions are quite beautiful. And I would defy people to say that they would know that, for instance, some of the breast reconstructions are not just the person's breasts, natural breasts. And an example of that would be my sister. She's had bilateral mastectomy and reconstruction, and I always say hers are better than mine now. Okay, so talking a little bit about targeted therapy, it attacks cancer cells by targeting the genes or proteins like we talked about. This is where that genomic profiling comes in, and targeted therapy might be IV, or it might be a pill, or it might be an injection. And not all cancers are treated best with targeted therapy. So sometimes that's where, chemotherapy has been around so long because it does work. And so many cancers, the standard of care is standard chemotherapy. And then immunotherapy, just to go over it a little bit more, what it does is it allows for either an unmasking of tumor cells that have learned how to hide from your immune system, and by unmasking the tumor cells, then your own immune system can get in there and start killing off cancer cells. Or it can just rev up your immune system so much that it is able to attack and kill those cancer cells. And that's what our immune system is designed to do. It helps to see cells that have become wayward, that are not normal anymore, and it usually knocks them out right away. But if your immune system has been suppressed, then that's when cancer cells can start to divide. And the immunotherapy kind of messes up that whole system of the cancer cells and allows for removal of them. And they're usually given by IV, intravenously, if everybody knows what that means. And then, as I said before, palliative and supportive care is extremely important. And supportive care, palliative care, that's basically to try to provide relief from the symptoms of pain, or the symptoms of stress, or symptoms of constipation or shortness of breath. Any symptom that a patient is having, there are tricks of the trade that could make those things better. And palliative care can be utilized right along with chemotherapy if that's the appropriate thing to do for the patient, to help to treat those symptoms. The whole goal here is to improve quality of life for people that have, as I tried to allude to before, cancers that we know we can't get rid of them completely, but certainly we can try to make the quality of life better for the patient while they're going through what they're going through. And because there are so many different treatments that are out there that are available to help patients, the ability to provide this extra care is extremely important, because people are living not for months like they were 30, 40 years ago. They're living for years with their disease, as if it were just their diabetes they need insulin for. So, it's nice to be able to have resources to help with symptoms that are side effects of the disease or side effects of the treatment. And palliative care is not the same thing as hospice. Hospice care is designed to help someone go through the dying process as peacefully as possible. And we use hospice for all kinds of diseases, not just cancer, but for heart disease and end-stage lung disease, all kinds of things that benefit from hospice. But palliative care is more concentrating on treating symptoms while you're living, okay? Hospice care is trying to improve your quality and treat those symptoms while you're going through the dying process. Even though we like to think that we're able to help everyone, cure everyone, we all know that's not possible. And as they say about, you know, taxes and all kinds of other things, you know, we none of us get out of here alive. We all are going to die at some point. We just would like to make it a much kinder process and maybe way far off. So the questions to ask during treatment, you know, the symptoms and the side effects that are affecting me most are, and tell your doctor. And you know, it's an interesting thing. Most of the time I walk in the room and I'll say, how are you doing? And the patient will say, I'm fine, how are you? After they've just filled out a paper with 20 things that are bothering them physically or mentally. So you can be nice and say you're fine, but you can be honest too and tell me what's really going on. You can talk about what's interfering with your life, your quality of life most. You know, is it the fact that you're so darn tired that you can't do anything? There are tricks to try to help with that. You know, how can we manage those symptoms? Are there other therapies that aren't chemotherapy or aren't pills that could help you? You know, how about medical marijuana? Would that help me? Would physical therapy help me? Would, you know, massage therapy or aromatherapy or Reiki or any of these other things that are considered to be above and beyond the medical part of things, but whatever makes a person feel better might be the ticket for you, you know. And then palliative care specialists, a lot of the groups that are considered to be hospice only actually have a palliative care component that's not hospice that you can be referred to. And a lot of the physical therapy places have a program that is designed specifically for patients who are having to go through chemotherapy or who have just finished chemotherapy and they're just whooped and they need to get their stamina back. So those are things to keep in mind. And I think we've talked about this a lot, that you have to keep track of your side effects so you can tell us what's going on. And one other thing too is, don't be afraid to call your doctor. I would much rather, and most physicians would much rather, hear about your side effect when it's happening so that we can come up with a plan to treat it, rather than you wait for 2 weeks till your next appointment and then tell us how awful you felt for those last 2 weeks. There's nothing worse, because sometimes a phone call is all you need to get some help. Squeaky wheels get the grease, okay? All right, then another thing to think about, and I tell everybody this, that, or I try to, that if you're thinking, do I need to get my things in order? Well, the answer is everybody should get their things in order. And a living will is powerful for you as a patient, because it tells me what you will do and what you don't want to be done, you know. If we don't know what your wishes are, we do everything from putting in a feeding tube to putting someone on a ventilator. And if that's not what you want, if that's not the kind of thing that you see for yourself, then you just write it down and tell us. It's not hard to do a living will or an advance directive. And all a durable power of attorney is the person that would be able to answer for you if you couldn't. So if you're unconscious, say you were in a car accident and you're unconscious and you can't tell what kind of things you want done, the durable power of attorney is the person that can speak for you. And that works too if someone has, say that I was developing dementia and it was getting worse over time. Well, then the durable power of attorney, and it could be anybody in your family, you just have to pick someone and fill out the papers. But that person could say, oh, before mom wasn't able to speak for herself and say what she wanted, she told me this, and it's written down here. And that way everybody knows what's going on. And then a financial power of attorney, I guess that's somebody different that can make decisions for you. Say you live alone and you don't have a big family. That's somebody that could say, okay, well, we know she wanted her great niece to have this, and maybe, arrange things for you. And that could be a big stressor off your mind if it's something that you took care of when you're thinking about it. A DNR means that someone's not going to be doing chest compressions on you or putting you on a ventilator. It doesn't mean that they're not going to care for you. So if you have sepsis or a bacterial infection in your blood, they're going to give you antibiotics and they're going to take care of you, everything, unless your heart stops or you're not breathing. And then at that point, based on what you've put down in your wishes, they would allow a natural death to occur. Sometimes to perform chest compressions and to put someone on a ventilator is not going to improve their cancer, or it's not going to make them live longer. It's just going to, well, it might technically make them live longer, but maybe not with quality. And if someone says, if you get put on a ventilator, there's a really good chance we would never get you off. Well, most people would say, well, then don't do that. So that's why it's important for us to know what people want, so we do the right thing by you. And a will, instead of a living will, is just, how you divvy up your whatever you have. If I have a chest from my grandma Dolores that I want one particular kid to have, then I can put that in my will. And then for those of you who are the caregivers, that's a really hard job, because you feel like you have to be doing something for your loved one, and you may feel very rushed into decision making about them. It's important to just kind of step back and think things through, and know that, so you can feel like you have a better sense of control and be calm during situations that are very difficult. And you can ask questions, think through the steps of what you want for your loved one and what you think they would have wanted if you're making decisions for them that they can't make themselves. And taking notes for yourself is just as important as the patient themselves taking notes. And then you can compare notes, and then you can have a nice discussion about, well, that's not what I heard. What about you? Well, you might interpret things a little bit differently, but then it's a good point to bring out to the physician, who could maybe straighten it out for you. And you have to take time to care for yourself. And caregivers get sick when they don't sleep enough and they don't eat enough. And once that person's sick, then you're done. So you have to be able to take care of yourself. So I think that pretty much wraps it up, Sam.
Okay, Dr. Childs, so I am going to turn your screen off and I'm going to share mine.
Okay. Hi. I recognize some faces out there. I guess I should, yeah, there we go.
Okay, so taking the next steps, so CSC has provided us with a lot of different resources that we can use to help members that come into our clubhouse, and also that physicians can recommend to their patients. So let's just go through a couple of those. So CSC has the Cancer Support Helpline, which is staffed by licensed mental health professionals Monday through Friday, 9 to 9. So if you have a question about treatment or you just need a little bit of support, that is a great number for you to call. And the number is 888-793-9355. And all of these resources, this whole slideshow, everything is going to be included in our email that goes out to members. So if you missed something during the presentation, don't worry, you can always come back to it later.
Or if you fell asleep or something like that, yeah.
We also have the Cancer Experience Registry, which is a little bit of a database that I'll go into a little bit more later. And that just helps medical professionals, social workers like myself, people that are in helping professions help you in a more effective way. We also have Open to Options, which is run by our research team at CSC. They help you put together a list of questions to ask to your doctor. They also have specialists that can kind of go through the concerns that you have about treatment or things that are coming up in your cancer treatment that you can put together so that when you go to that appointment, you feel prepared and empowered and ready to go. We also have what we're doing right now, which is frankly speaking about cancer. So these are a series of lectures, books that you can download off of CSC's website, just resources that you can go through or watch like you're doing right now to learn a little bit more about the cancer experience and things that you might go through as you go through your own cancer journey. So like I said, I'm going to go a little bit more in depth to the Cancer Experience Registry. So this is a research survey that Cancer Support Community runs at all of their affiliates, and it's to help them better understand what you need emotionally, socially during your cancer journey. So this data is used to help medical professionals, social workers like myself, just anyone who's on your oncology team really understand what your needs are outside of the medical part of it. And everything is confidential and secure, so you never have to worry about your information falling into the wrong hands. So this is just a timeline of the different cancer experience registries that have been created. You can see that there are specific ones for specific cancers. There's a multiple myeloma, a lung cancer, prostate cancer, ovarian cancer, and there's also surveys that are specific to caregivers because you're part of the team too, and we want you to feel just as supported as the person who's going through cancer treatment. So how can you join? You can go to cancerexperienceregistry.org, and registration is really easy. It's only 3 steps. You agree to the informed consent, submit your email, and select your primary cancer or caregiver status, and complete your profile. And then once you fill out the survey and set up your page, all of that information is sent to CSC's research team so that we can create educational resources that'll really help you through your own cancer journey. So Cancer Support Community also has a grassroots movement. So if you're looking to get involved on the legislative and the political side of medicine and cancer treatment, a little bit of insurance reform, you can certainly do that. You can be an advocate for other people in your community and in your country that are affected by cancer. So this community has up-to-date information on key issues. Usually they put out a lot of press releases about things that are coming up in Congress or the House of Representatives. And you can join this national network of people who are advocating for others with cancer. We also have My Lifeline, which is a little bit more of an interactive site. It allows you to let your family and your friends know how treatment is going for you without, sending out a million text messages all the time. It also has a helping calendar, which helps you find volunteers in your area that might be able to help you with meals, rides to treatment, errands, childcare, pet care, you name it. They probably have a volunteer out there that can help you with it. They also have discussion boards. So if for some reason you're in one of our support groups and maybe you had a question that didn't quite get answered, you can go onto their discussion boards and talk with other people that are going through cancer treatment right now, see what their experience is like, and connect with people who you may not be geographically very close to. They also have care coordinators. So this kind of makes your whole cancer experience a little easier because you can assign family and friends to help with very specific things because pretty much the number one thing we get from caregivers is, I just want to know how to help. So this is how you can let them know. And just like the Cancer Experience Registry, everything on this site is completely secure. So you don't ever have to worry about your information or your loved one's information falling into the wrong hands. All right, so now we'll open it up for questions and discussion. I am going to stop my share. All right, so if anybody has any questions, you can either enter them in the Facebook comments or you can enter them in the chat here. So it looks like we have one from Eleanor and Barry. In choosing a treatment plan, how can a patient find out outcomes using radiology alone versus ADT and radiology?
So that's a very detailed question. And I think it is mostly determined, I mean, this is with regard to prostate cancer. So this is going to be determined by what stage the prostate cancer is, what grade the prostate cancer is, and they also have a grouping, a new thing that kind of tells you how aggressive theoretically the cancer could be. And it, depending on where it falls in that spectrum of how aggressive, is when you would maybe consider doing both at once. And this is for prevention of recurrence in the majority of cases. So your best resource is going to be the medical oncologist and the radiation oncologist who are giving you the data. And some of us are nerdy enough where we could maybe even pull an article for you and say, well, this is the most recent one that tells us why this is better. So good question.
Okay, well, is there any others that pop up from our Zoom or from Facebook here? All right, so it looks like everybody is all set. If you have a question that comes up later and you didn't get to ask it, you can always send me an email. My email is samantha@gildasclubsouthjersey.org. So if you have a question for Dr. Childs and it pops up later, you can always send it to me. I'll send it her way. Dr. Childs, I just want to thank you so much for taking time out of your evening to be with us and share all this great information. And again, if you missed anything during this presentation, if you had to kind of duck in and out, all of it will be available on Facebook, YouTube, and we'll be sending all the slides out over email. So if you missed anything or you didn't quite get a link, don't worry, you'll be getting it tomorrow. So again,
and it's nice to see some friendly faces out there. I know some of you guys. Actually, I think I know at least 3 of you. Anyway, thank you, and everybody have a great night.
Thank you. Have a good night, everybody.
Bye.